Bleeding and hemostasis in cardiac surgery. So this is the coagulation pathway, which shows extrinsic and intrinsic pathway, and they merge into a common pathway. And there are few tests performed to see the bleeding and coagulation status of a patient. The most important is APTT. APTT is the indicator of intrinsic and common pathway and used to monitor heparin. INR, the prothrombin time and its derivative measures of prothrombin ratio and international normalization ratio are measures of extrinsic pathway. Measure of warfarin, vitamin K status, and measures factor 1, 2, 5, 7, and 10. TAG is thromboelastogram. It is one of most important tests performed in cardiac surgery. It has 4 values: R value, K value, angle, and maximum amplitude. So it can show various things like a normal coagulation status, anticoagulant and thrombohemophilia, and platelet blockers, fibrinolysis, hypercoagulation, and state of DIC. ACT, activation of coagulation via intrinsic pathway, that is factor 12. In most of the cases of cardiopulmonary bypass, a dose of heparin is given around 300 to 400 international unit and is administered prior to coronary bypass, cardiopulmonary bypass, with additional boluses as required to maintain the ACT more than 400. Platelets and other products are given to correct these coagulation problems. So if platelets is given, obviously it's going to increase the platelet count, and usually given in the quantity of 50 mils. ABO compatibility is required, usually of single donor, and need a proper storage and have a shelf life. FFP, they contain coagulation factor, raise most of the clotting factors, and given around 50 to 250 mils, and single donor, and it could be pooled, needs ABO compatibility, storage requirements are there, and can be given antithrombin deficiency. Cryoprecipitate, they increase fibrinogen, factors 7 and 8, 1 bag is equal to 20 mils, and ABO enriches compatibility is not relevant. Other product is prothrombin complex concentrate, clotting factors 2, 7, 9, and 10, protein CNS, reverses warfarin in the cases of significant bleeding in patients with a coagulopathy, INR of more than 8, and prolonged prothrombin time and raised D dimers. Infective risk of transfusions, and they can cause bacterial contamination, HIV, hepatitis C, hepatitis B, syphilis, Chagas disease, cytomegalovirus infections, and HTLV. Now treat those conditions in cardiothoracic patients. Sometimes need topical hemostats to control bleeding during the surgery. So the first is oxidized regenerated cellulose. It's a local hemostatic bioabsorbable gauze, and it provides a scaffold for the platelets, absorption time, and it's a bacteriostatic. Fibrin sealant, they are composed of freeze-dried concentrate of clotting proteins, factor 13, fibronectin. Freeze-dried thrombin act as a catalyst, effective in patients with coagulopathies and patients on warfarin. Polyethylene glycol polymers or PEG, they provide rapid cross-linking of collagen, control of bleeding from anastomotic graft, reduced adhesion formation in post-cardiac surgery. Bovine albumin and glutaraldehyde, flexible mechanical seal independent of body's clotting mechanism, adheres to synthetic graft, not recommended in pediatric surgery. Gelatin and thrombin. Gelatin is a bovine derivative and thrombin is, uh, is a human derivative. They have a tamponade effect and clot formation. Recombinant thrombin for controlling minor bleeding and capillaries in small venules, but ineffective and not indicated for massive brisk arterial bleeding. So the references are from a review of topical hemostatic agents for the use in cardiac surgery by James Bernard and our respected consultant, Mr. Russell Milner from Blackpool Victoria Hospital.